Hello, my name is Jenny Pagel-Guile. I am the Executive Director, and on behalf of the National Pancreas Foundation, thank you for viewing this webinar. You are part of our mission, and as we focus on supporting the education of our care providers, patients, and our medical community. We also want to provide additional information, so you are able to follow us on Facebook. We have a new Facebook page. Make sure that you can follow us for all the up-to-date information and upcoming events that we have in your community. And we are also on a variety of other social media platforms for you to follow. In addition to your participation in this webinar, we are always looking for volunteers. So if you would like to be a presenter of a webinar and have a subject that you are interested in presenting on, or if there are events in your community such as Pancreas Bowl, we have galas, we have advocacy efforts, and a variety of opportunities to engage with the National Pancreas Foundation. And we look forward to seeing you soon.
Our moderator for this module will be Dr. Kevin McGrath. Dr. McGrath is a professor of medicine at the University of Pittsburgh and director of Endoscopic Ultrasound program at UPMC.
Thank you, Jenny, for that warm introduction and welcome. This webinar series is entitled Navigating Pancreatic Cysts, Classification, Treatment, and Management. This is an important and timely topic as we are finding more cysts due to increased use of abdominal radiographic imaging. The vast majority of cysts are benign, but it's our job to try to further classify these cysts and determine whether there is any malignant potential. We also want to avoid any unnecessary pancreatic surgery. Through these topics today, you'll learn more about classification, the further evaluation and management of pancreatic cysts, and whether surgery is indicated.
So with that, our three speakers are all advanced endoscopists here at the University of Pittsburgh Medical Center. All three have been trained in advanced endoscopy and have received specialized training in EUS and ERCP at UPMC. Their research and clinical interests are related to pancreaticobiliary endoscopy and pancreaticobiliary malignancies, along with acute and chronic pancreatitis and pancreatic cystic lesions. In part two of our series, Dr. Rohit Das will be speaking on the diagnostic evaluation of pancreatic cysts, which involves cyst evaluation, imaging modalities, use of EUS, cyst fluid analysis, and molecular analysis. Dr. Das practices at UPMC Shadyside and UPMC Presbyterian, where he is an assistant professor of medicine.
Thank you for the introduction, Dr. McGrath. I'd like to thank you as well as the National Pancreas Foundation for the opportunity to talk to you about the diagnostic evaluation of pancreatic cysts, which is something, a topic that has really evolved over the last 1 to 2 decades, and UPMC has actually been at the forefront of advancing this field. So as an overview of this talk, we'll first begin with a very brief summary of the etiology of the different types of pancreatic cysts. And this will be a brief conversation about this topic, mainly because part of this lecture series will include a much more thorough discussion of the classification of different types of pancreatic cysts. But I think a brief introduction of this topic is important to provide a foundation for why diagnostic testing is important. We'll then discuss the 2 main modes of diagnostic evaluation of pancreatic cysts. This includes imaging evaluation in the form of CT and MRI. And then finally, and this will be really the brunt of our conversation today, will be endoscopic ultrasound or EUS guided evaluation of pancreatic cysts. And this includes cyst fluid analysis, cytology and tissue acquisition, and molecular analysis. And we'll go into all of these in detail. So I thought it would be nice to talk through a case presentation over the course of this talk as a way to just demonstrate the steps of evaluation that patients generally go through when a pancreatic cyst is found. So this is a patient that I've been taking care of over the last few months. She's a 69-year-old woman, pretty healthy, just a history of hypertension and diabetes, who presented to our local ER with a few weeks of diarrhea after a recent course of antibiotics for a dental issue. And ultimately, she was found to have Clostridium difficile and received a course of vancomycin and felt better. But she did have a CT scan done as part of her evaluation. And this is a static slice from that CT image. And as you can see, as delineated by that red arrow, she had a 3 centimeter, approximately 3 centimeter cyst that was found in the head uncinate area of the pancreas. So, of course, she was pretty terrified. Generally speaking, whenever patients are told that there's something in their pancreas, they have these types of questions. Is it cancer? What do we do next? Do I need surgery? And, it can be a pretty frightening thing to hear that elicits a lot of anxiety. So our job as GI physicians and endoscopists who look at pancreatic cysts is number one, to help educate patients and also reassure them. Because the reality is that due to widespread use of cross-sectional imaging, pancreatic cysts are being found much more frequently. In the right population, in the middle-aged population, pretty large prospective studies have been shown that pancreatic cysts are very common, and in the right cohort can be found in up to 30–40% of people. And as in this case, most often pancreatic cysts are diagnosed incidentally, meaning that they're there, but they have nothing to do with the initial symptoms that the patients presented with and precipitated cross-sectional imaging. So we do make efforts to try to educate patients about the fact that there are several different types of pancreatic cysts, some of which are completely benign and harbor absolutely no malignant risk, and then others that do have a malignant potential. So mucinous cysts, which are actually the most common type of cysts that we diagnose, do harbor a malignant potential, but that malignant potential varies very widely to basically a negligible risk to a high enough risk that may warrant pancreatic surgery. The two mucinous cysts that we encounter include mucinous cystic neoplasms, or MCNs, and intraductal papillary mucinous neoplasms, a very long word which we shorten by calling them IPMNs. And as alluded to on the other side of that table, non-mucinous cysts, aside from cystic neuroendocrine tumors and solid pseudopapillary tumors, these do not harbor any malignant risk. So because of the different prognoses of different types of pancreatic cysts, the goal of diagnostic evaluation is really to tease out the type of cyst so that we can better educate patients about what the next steps are, and also, in the case of mucinous cysts, to help determine the risk of malignant potential down the line. Cross-sectional imaging, mainly in the form of CT imaging, is often the first line of defense, so to speak, for pancreatic cysts, mainly because patients get CT scans. Once you walk into the ER, it's part of the evaluation generally. And CT is very widespread, it's very available, and it's easy for patients to tolerate. These are two selected images that I wanted to just highlight just to show how CT can be pretty useful in the right circumstance. On the left, we have a classic appearance of a serous cystadenoma, which is characterized by that multicystic appearance and sunburst calcification in the center of the lesion. And on the right, and I'll try to use the pointer here, you can actually see a dilated main duct of the pancreas, which would be very consistent with main duct IPMN, which is a high-risk pre-malignant condition that could warrant referral to our pancreatic surgical colleagues. So how good is CT scan in evaluating pancreatic cysts? This was a pretty large systematic review. It was published in Pancreas about 6 years ago. It's included 22 studies and over 1,500 patients with pathologic correlate to help decide how did CT scan and the CT impression correlate with what was found on final pathology. And to summarize some of the pertinent points from this study, CT imaging was actually only 30 to 50% accurate in reaching a diagnosis for a cyst type. So essentially a coin flip. And in regards to differentiating between low and high risk pathology, and on imaging, the characteristics of high risk pathology include solid lesions, mural nodules, which are little solid growths within mucinous cysts, and dilation of the main pancreatic duct, as we showed on the CT scan on the previous slide. CT was actually pretty decent in differentiating between benign and malignant disease with an accuracy of 60 to 80%. So the bottom line is that CT is really not a good test for determining cyst type. Again, basically a coin flip, which is not acceptable for a diagnostic test, but it is pretty good in differentiating between low and high risk disease. So after my patient got the CT scan done, she was recommended to have an MRI to help better characterize the cystic abnormalities of her pancreas. And MRI is generally used as the second step in evaluation after initial CT imaging. But the caveats for MRI are that they're not as widely available, especially in Pittsburgh these days. People are getting scheduled 2 to 3 months out for MRIs. And so it's not nearly as widely available as CT imaging. And MRI is harder to tolerate for a lot of patients, mainly due to claustrophobia. And so as a consequence of that, the quality of MRI may not be as good. But that being said, my patient did undergo a pretty good quality MRI. This is actually an MRCP image, basically an MRI reconstruction of the biliary tree and the pancreatic duct. And I've highlighted the main abnormalities of note here. As delineated by the red arrow, you could see that she has that large cystic lesion in the head uncinate process of the pancreas. And then she also has several other cysts in the body tail region of the pancreas, which are encircled by that red circle there. And so the multiple nature of this pancreatic cystic abnormality, as well as the fact that the cysts appear to be communicating with the pancreatic duct, is pretty diagnostic for IPMN. So in this same study, they also looked at MRI. So how did MRI fare in this large systematic review? It was more accurate than CT scan in diagnosing cyst type with an accuracy of 50 to 86%, depending on the study that was looked at. And that's mainly because, as alluded to in the previous slide, MRI is better able to define cyst communication with the main pancreatic duct, which is very consistent with IPMN. And MRI is also better at identifying some of those high-risk imaging features, including mural nodules, and also better defining the internal architecture of cysts. But ultimately, the accuracy for differentiating between benign and malignant cysts, at least in this study, was pretty similar when MRI and CT were compared with each other. So as a summary for MRI, it is better in diagnosing cyst type as compared to CT scan, and that's important. But in regards to differentiating between low and high risk disease, they're pretty similar. So just to summarize in regards to cross-sectional imaging, CT and MRI are the commonly used cross-sectional imaging techniques to evaluate pancreatic cysts, with CT being much more commonly used because of its wider availability and easier to tolerate for patients. MRI is better than CT at diagnosing cyst type, but neither modality is reliably accurate in this regard, and essentially a coin flip. But both imaging modalities have a decent accuracy for differentiating between low and high risk disease. But practically speaking, it's always important to have some sort of cross-sectional imaging study prior to pursuing an endoscopic ultrasound. And that's because as endosonographers, we like to have a good lay of the land and have a game plan as to what we expect to see and what we wish to biopsy before doing an EUS. So that's a good segue into now discussing endoscopic ultrasound, or EUS for short. EUS is an endoscopic procedure where an endoscope is actually fitted with an ultrasound probe right at its tip, and that ultrasound probe allows us to look at the structures adjacent to the esophagus, the stomach, and the first part of the small intestine. This includes, of course, the pancreas, and with tools that are able to go through the working channel of the EUS scope, we're actually able to biopsy cysts and other lesions of the pancreas with pretty feasible and easy to perform techniques with the appropriate training. This is overall a very safe procedure. If a cyst is sampled, there is a slightly increased risk of adverse events, including bleeding, infection, and pancreatitis. But based on large studies, the overall risk of a major complication, even with a biopsy, is pretty rare and on the order of 1 to 2% at most. But it is important to remember that EUS, though low risk, even when we sample something, is an invasive procedure. It requires anesthesia, and it's not at all widely available. We have patients that travel 2 to 3 hours all around the Western PA and Eastern Ohio area to just get an endoscopic ultrasound. So that begs the question, when do we pull the trigger? And this is actually a really difficult question to answer. Different societies have different recommendations and guidelines, and as a consequence of that, as we'll talk about, different institutions have different practices. So as per the guidelines that were published by the American College of Gastroenterology in 2018, they recommended that EUS be performed when the diagnosis is unclear. And remember, imaging is basically a coin flip at best. So most of the time, the diagnosis is unclear. And EUS is only recommended if cyst fluid analysis is expected to change management. So obviously, this is a very vague recommendation, and they admit that it's conditional with a very low quality of evidence. They do provide this algorithm to help clinicians decide when to pursue EUS. And I've just highlighted in this complicated algorithm, I've highlighted what's most important here. And as you can see, when a cyst is seen on imaging, assuming there's no evidence of obstructive jaundice or biliary obstruction, and assuming there's no associated solid mass, and both of these would represent higher risk pathology even before an EUS. They recommend that an EUS be performed if one of 3 criteria are fulfilled, including main duct diameter of greater than 5 millimeters, a cyst greater than 3 centimeters in size, or associated main duct caliber increase with gland atrophy. And that third criteria basically refers to imaging stigmata that are really concerning for a solid lesion. So if you fulfill one of those 3 criteria, based on this algorithm, the American College of Gastroenterology recommends that an EUS be performed. In reality, this is probably only a minority of patients, and our group was concerned that these types of guidelines would miss a lot of higher risk pre-malignant pathology that would only be detected and appreciated on endoscopic ultrasound and appropriate cyst fluid analysis. So we conducted our own retrospective study. This was published in 2016. It included 225 patients who had operative management of pancreatic cystic lesions. And we basically looked and saw and tried to determine how did the societal guidelines accurately predict high-risk pathology. And so this study, we actually used the AGA guidelines, which are very similar, just trust me on this, to the 2018 ACG guidelines. And we applied those guidelines to this 225 patient cohort. And for identifying advanced neoplasia or high-risk pathology, and that includes high-grade dysplasia, pancreatic neuroendocrine tumors, and overt cancer, the guidelines actually perform pretty poorly with a sensitivity of 62% and a specificity of 79%. And furthermore, 15% of patients who had serous cystadenomas or other benign pathology would have been missed by these guidelines. And that's important because when we identify benign lesions, not only can we reassure patients and relieve that anxiety, but also we can avoid all the unnecessary diagnostic testing that comes with the diagnosis of pancreatic cysts of unclear etiology. So based on this data, our group created our own algorithm, which essentially provided a lower threshold to perform EUS and incorporated molecular testing into our analysis. And we'll talk about molecular testing in more detail later. But with this algorithm, we were much more accurate in determining higher or identifying higher risk pathology with a obviously very good sensitivity and specificity. So we essentially consider EUS in anybody who fulfill one of those 5 criteria: a cyst greater than 1.5 centimeters in size, high-risk imaging stigmata, including a solid component within the cyst and a dilated main pancreatic duct, or clinical symptoms related to the cyst, or a family history of pancreas cancer. So for my patient, her cyst was at least 3 centimeters in size on cross-sectional imaging, so it was a pretty slam dunk decision to perform an EUS. On the EUS image on the left, you can see that the cyst was at least 36 millimeters in maximal cross-sectional diameter. It had a septated appearance, but otherwise no solid lesion, no mural nodule, and no dilation of the main pancreatic duct on her complete EUS exam. I did decide to perform fine needle aspiration. That's shown on the picture to the right. You can see the needle within the cyst. And we collected some mucin-containing fluid and sent that fluid for the following tests: CEA, glucose, cytology, and molecular testing. And so now we'll talk about these tests and then circle back to this patient, look at her results, and see what panned out. So the 2 tests that are almost always sent as part of cyst fluid analysis include CEA and glucose levels. CEA is the tumor marker that is preferentially secreted in mucinous pancreatic cysts. The accuracy of this test really depends on the cutoff that's used, which varies by laboratory, but the higher the level, the more likely the cyst is mucinous. So in one study that was published in 2004, which goes to show how long this test has been around and again, pretty widely studied and used, with a cutoff of 192 nanograms per milliliter, the sensitivity was okay at 73%, but a decent specificity of 83%. What's important to note, though, is that the extent of CEA elevation does not correlate with advanced neoplasia or high-risk disease. So it's a decent test to identify a mucinous cyst, but it does not at all predict or accurately identify higher risk pathology. Glucose levels in pancreatic cysts has been more recently studied and gaining a lot of traction. It has been shown to be quite accurate in differentiating between mucinous and non-mucinous cysts, and probably better test than CEA. In one study that was published in 2022, a glucose level less than 25 had a sensitivity of 88% and a specificity of 91%, so very accurate. And several studies have actually shown that glucose levels within cysts performs better than CEA levels. And in addition, CEA requires a decent amount of cyst fluid, and that's important because in smaller cysts, we may not be able to collect a lot of fluid. A glucose level only requires a few drops and actually can be performed in real time during the procedure if you have the right tools and equipment. We will also often send cyst fluid for cytologic analysis, which is basically looking at cyst cells under the microscope and trying to characterize as to whether there's any changes of advanced neoplasia. The issue, though, is that cyst fluid is often very acellular, or rather paucicellular, meaning that there's not a lot of cells to look at within the fluid. And as a consequence of that, the sensitivity of cytology is unacceptable, 30 to 40% at most. But it is useful in the sense that if advanced neoplasia changes, neoplastic changes, or malignancy is found, it is very specific as expected. There are additional modes of acquiring tissue during endoscopic ultrasound, and I just wanted to highlight this technique because it is gaining somewhat more traction over the last few years. This technique is called through-the-needle biopsy, or TTNB for short, and this represents a technique where via EUS, we're actually able to obtain direct biopsies of the cyst wall for histologic analysis. And this is done through a biopsy forceps that can actually go through the sheath of needles that we use during EUS. Studies have shown that obtaining 2 visible biopsy samples seems to provide the highest yield. In a large meta-analysis that was published 5 years ago, for diagnosing a mucinous cyst, TTNB was actually very accurate, with a sensitivity of 90% and a specificity of 94%. But there is a caveat. TTNB definitely does add a higher chance of an adverse event. There's up to a 10 to 20% chance of causing bleeding, causing pancreatitis. So in our practice, we really reserve this technique when standard measures, standard cyst fluid analysis, molecular analysis fails to provide a diagnosis, obviously, of course, after discussing the risks and benefits with the patient. So the final diagnostic test I wanted to talk about, and certainly not the least, is next generation sequencing. And this testing, this platform has been pioneered by Dr. Atur Singhi from the UPMC GI Pathology Department in collaboration with our EUS group. And this testing has really significantly advanced how we approach pancreatic cysts, and honestly has been a true game changer in the field. So next generation sequencing refers to rapid throughput DNA analysis for mutations of interest. And this technique, this technology, has been applied throughout basically every subspecialty in oncology. And Dr. Singhi has really focused this platform on pancreatic and biliary pre-malignant and malignant pathology. So we're able to do this because DNA does collect and accumulate within pancreatic cysts from lysed epithelial cells, and we can collect this DNA with standard fine needle aspiration techniques and standard methods of collecting cyst fluid. And when we then preserve the DNA in specific DNA preservation vials, that DNA can then be extracted and rapidly analyzed for multiple mutations that are associated with specific cyst types. And furthermore, for mucinous cysts, we also look for high-risk mutations that would identify high-risk pathology that otherwise would not have been found with standard diagnostic techniques that we've already discussed. This test does have about a 7 to 10-day turnaround, and we do inform patients of that, that we're going to be in touch with you in a week or so, and then with these results, provide subsequent recommendations. So our group recently published a very large prospective multi-institutional study looking at the accuracy of a 22-gene next-generation sequencing panel that we've termed Pancreas-Seq. And this study prospectively looked at nearly 2,000 patients with pancreatic cysts who had surgical resections, and use that cohort to determine the accuracy of our NGS panel. And so this diagram from that paper, I think, very nicely shows how different mutations correlate with different diagnoses. And so going from the top to the bottom, in red, you can see that mutations in GNAS, which is an oncologic protein, and proteins involved in the MAP kinase or MAPK signaling pathway, are highly associated with mucinous cysts. These mutations in GNAS and MAP kinase are diagnostic for mucinous cysts, but do not predict high-risk pathology. High-risk genes, on the other hand, like TP53, SMAD4, CTNNB1, mTOR, to name a few, these genes not only are associated with mucinous cysts, but also are very predictive of advanced neoplasia. And the additional aspect of Pancreas-Seq that really sets it apart from other NGS platforms is the fact that it has the ability to detect mutations associated with non-mucinous cysts, specifically mutations that can identify neuroendocrine tumors, solid pseudopapillary neoplasm, and serous cystadenomas. And in the case, again, of non-neoplastic, non-mucinous cysts like serous cystadenomas, identification of such lesions can be really beneficial for patients and avoid unnecessary downstream testing. So how did Pancreas-Seq perform in this study? These are some of the major take-home points of this very large study. Mutations in the MAP kinase pathway, which include proteins like KRAS and BRAF, and mutations in the GNAS protein were 90% sensitive and 100% specific in diagnosing mucinous pancreatic cysts. So very accurate in regards to diagnosing these type of cysts. In addition, this panel was pretty accurate in identifying higher risk genes with a sensitivity of 88% and a specificity of 80%. And then finally, for serous cystadenomas, which are the most common type of non-mucinous cysts, VHL or von Hippel-Lindau mutations were 71% sensitive and 100% specific. So overall, this platform is very accurate, and especially for mucinous cysts, and outperforms basically all of the diagnostic tests that we talked about, and in addition, doesn't really add any additional risk or use of additional tools to standard diagnostic EUS. This technology is really gaining traction. It's being used by multiple different institutions now. More and more insurance plans are beginning to cover it, but there are still some that have yet to accept it. The out-of-pocket cost for this test is $750. So, it's something that we do look out for if the given patient's insurance plan covers it or not. And if it doesn't, we do offer the out-of-pocket cost if the patients are willing to pursue that. So what were the results for my patient? So her cyst fluid analysis showed a CEA of 156, which was slightly elevated. Her glucose was undetectable. And so remember, an undetectable glucose level is very predictive of a mucinous cyst. Her cytology was suspicious for neoplasm, which is a very nonspecific terminology, which again is most consistent with a mucinous cyst. And then most importantly, her pancreas-seq only showed a KRAS mutation, which is diagnostic for a mucinous cyst, but it did not show any high-risk genes. So she's now on a surveillance protocol with MRI every 6 to 12 months. So as an overall summary, pancreatic cysts are a common occurrence and often incidentally found on cross-sectional imaging done for other indications. Mucinous cysts are the most common type of pancreatic cysts and harbor a very variable malignant potential. CT and MRI imaging are not accurate for defining cyst type, but are reasonably accurate for differentiating between benign and high-risk disease. EUS with fine needle aspiration of cyst fluid analysis is commonly employed for diagnostic evaluation of pancreatic cysts where available, but data is lacking in regards to when to best utilize this diagnostic tool, and clinical practice does vary. And then finally, NGS is a very accurate test for defining cyst type and identifying advanced neoplasia, and slowly but surely becoming the standard of care in diagnostic evaluation of pancreatic cysts. So that's all I have. And again, I would like to thank the NPF for the opportunity to talk to you, and have a good day.